Heart failure literally means an impairment of the heart to function as a pump to support the circulation. Causes of heart failure are hugely variable. Commonly, it is caused by ischemic heart disease, hypertension, or cardiomyopathies, but there are many less common causes that can range from congenital heart disease to certain infections. In heart failure, the heart is weakened, so cannot eject as much blood in each heartbeat as it should. This is a decrease in stroke volume. The heart has many mechanisms to compensate for this decrease, but the body quickly becomes overwhelmed by these mechanisms and they become harmful. The first mechanism of compensation we're going to talk about is an increase in venous pressure. This occurs because, in reality, the heart and vessels are like a closed loop, and because the left ventricle is failing to pump an adequate amount of blood out of the heart, there is a backflow of venous blood trying to get into the heart. This backflow is what creates the increased venous pressure. The increased pressure then leads to an increased alveolar and interstitial fluid, contributing to the main side effect of left-sided heart failure, pulmonary edema. Another compensatory mechanism in heart failure causing pulmonary edema is activation of the renin-angiotensin-aldosterone system. This occurs when there is a decreased cardiac output, leading to decreased perfusion of the kidneys. When this happens, the kidneys think that the body doesn't have enough blood. For example, if there was a hemorrhage somewhere, when really it's just that the heart isn't pumping the blood that's already got around the body well enough. When the RAS system is activated, it causes retention of salt and water, and obviously this creates a higher volume of blood in the body and therefore an even higher venous pressure. The increased venous pressure and the pulmonary edema are the main causes of cough in heart failure. Essentially, there is too much fluid in the body and the heart isn't capable of moving it adequately around, so it is stuck in the veins. In particular, the blood congested in the pulmonary veins begin to leak fluid and the lungs begin to fill up. This fluid in the lungs causes shortness of breath as well as a cough. This cough may be dry or productive of pink, frothy sputum in severe cases. The mainstay of treatment for pulmonary edema is a diuretic. In particular, a loop diuretic, usually furosemide, which can be given either intravenously if it's an acute case or orally for more long-term management.
Furosemide works on the nephrons of the kidneys. The nephrons have various segments which reabsorb solutes and water. Each tubular segment has a different luminal membrane permeability, depending on the membrane proteins and their differing permeabilities to solutes and water. Furosemide targets the thick ascending limb of the loop of Henle, hence is classed as a loop diuretic. The thick limb of the ascending loop of Henle reabsorbs approximately 20 to 25% of the filtered sodium and is relatively impermeable to water movement. As a result, solutes are reabsorbed in greater quantities than water, resulting in a net dilution of the tubular fluid. The kidneys utilise both simple and facilitated diffusion of solutes along an electrochemical gradient, as well as active transport to transport water and solutes across the membrane. The electrochemical gradient is driven by the sodium-potassium ATPase pump on the basolateral membrane. Additionally, there is a sodium-potassium chloride cotransporter on the luminal surface. Paracellular diffusion of sodium, potassium, calcium, and magnesium also occurs. Furosemide inhibits the sodium-potassium chloride cotransporter through competitive inhibition at the chloride binding site on the cotransporter. This means that the transport of sodium from the lumen of the loop of Henle into the cellular interstitium is prevented. As a result, the lumen becomes more hypertonic than the cellular interstitium. The osmotic gradient for water reabsorption in the nephron is diminished and dilute urine is produced because furosemide impairs the nephron's ability to concentrate the urine. Furosemide is a very potent diuretic. It reduces the patient's overall intravascular volume, which, in turn, decreases pulmonary vascular pressures. Venous capacitance increases and the intrapulmonary fluid, which has led to the patient's cough and dyspnea, returns to the circulation. Furosemide treatment does carry certain risks, such as hypokalemia and hypomagnesemia, which can predispose to complications such as arrhythmias. All patients, therefore, must be regularly monitored and checked for electrolyte imbalances.